Okay. All right. So today's lecture, as all of you know, is on advocacy. Um, I do have on the PowerPoint some embedded videos that y'all can look at y'all's leisure when you're studying, because it's kind of difficult to go back and forth with us sharing the screen. So y'all can look at that. But the lecture should give you everything that you need to be successful on the test. But the videos help to kind of clarify a lot of things that, it's not, not many videos, but I do have videos that kind of help clarify some things that we'll be talking about today. So, let me share my screen and get started. Come on, slideshow. There we go. All righty. So I don't go over the SLOs, so y'all can look at those. We'll just kind of get on with the lecture. All right. So when we're talking about advocacy and nurse advocacy, we got to kind of start with a little background. So, for nurses, it's important, of course, for us to deliver quality care. But there's more to that. We are the patient's advocates. We help them make informed decisions. We help them navigate through the complex medical system. We help translate terms, and that's a lot of things that y'all are going to be doing when it comes to nursing. Y'all are going to really talk in layman's terms about a lot of things, because we have to realize that the majority of our patients probably have a 5th grade education. So, you'll have a provider go in and they're talking to the patient, and the patient will sit there and shake their head like they understand, and they really do not. And that's why it's important for us that when we go in and assess them that day, if it's a new patient, to make sure that we understand their or get an idea. Don't ask them their educational level, but through conversation, determine what their educational level is, so you'll be able to translate certain terms. And even if somebody tells you that they are a meteorologist or an attorney, still does not mean that they are familiar with a lot of medical terminology. We also help patients make ethical decisions, because you have to understand that as nurses, we have the most direct interaction with the patient. Other than any other person who may walk in the room, they see us the most. So we're really ideally positioned to be advocates for our patients. So understand, as an advocate, we are communicators, we're liaisons for our patients, we're educators, we're interpreters, and we're caregivers. And you have to realize that, successfully advocating for our patient really does help with their overall healing process. So as an advocate, we protect our patients, we defend them from harm, we help represent their needs and wishes, and it really can be a positive experience for us and the patient. So when we're talking about advocacy, we do several things. The slides kind of mention it, but I'm going to go over it. But we preserve human dignity. And what that is that, a person comes in, they're scared, they're confused, they don't know what to expect. And as nurses, we're there to help calm some of those anxieties, calm some of those fears that they will be going through, and the patient and the patient's family. Um, and when we talk about interpreting medical terms, we're also talking about being familiar with the test that they're going to be undergoing. Make sure that you're know about the procedures, their medications. That's why it's important for you to know what they're taking. That's why we ask you to go into the patient's room, educate them on, or at least tell them what they're taking, and tell them about if there are any potential side effects or things that they need to know, especially at discharge planning. We really are in a good position, like I said, to address the patient's needs and help them accomplish whatever goal it is. Of course, the goal would be I want to get better and get out of the facility. So we're helping them accomplish that goal. We also help with patient equality. When y'all start, and if y'all are already in the medical field, but when you really get into medicine, you'll start to realize how finances affect everything. And sometimes that can put certain individuals in positions to where they may not be able to receive certain healthcare services. So we have to make sure that even though there may be some friction within the medical organization, but we have to make sure that that patient receives compassion, that we have to respect their dignity, their worth, their uniqueness, regardless of their social or economic status, any personal attributes, or any health problems. And that's part of the ANA Code of Ethics. So ANA is American Nursing Association Code of Ethics. We really have to make sure that regardless of who the patient is, that they receive the same care as anyone else. As y'all get into nursing practice, y'all will see the disparities that they do have in medicine if you haven't seen it already. We have to make sure that our patient is a priority. And this will happen when a patient is diagnosed with a terminal illness. And the family, now this person is competent, they're alert, they're competent, they're receiving the information, so we're educating them as best as we can so they can make informed decisions about their care. And their family may disagree with the care, but we have to make the patient our priority. We have to listen and adhere to their wishes, even if we may not agree with it. But that's what we have to do. And regardless of what the family decides, we do what the patient asks us to do. And that's making our patients a priority. We're not putting anybody ahead of them. Because you'll find that happening in your nursing career. You'll find where family members will say, well, don't tell them they have stage 4 cancer, or don't tell them this. And we'll talk about that in a little bit. But if the patient wants to know information, we are obligated to tell them that information. Now, if you feel uncomfortable with it, then you can always relay that to the provider so they can go in, because we want to be truthful to the patient so they can make an informed decision on what type of care that they want to receive after hearing about their diagnosis and how severe it may be. We want to help our patients be free of suffering. So we want to be able to help them on their physical level, emotional level, psychological level. And, this is one important part of patient care and being a patient advocate, because we need to try our best to identify certain certain clues that will tell us that our patient is dealing with something. If you notice that a certain diagnosis, or if you notice that a patient is dealing with, well, I guess you can say, if you notice that your patient is sad or depressed, we have to go in and try to address those concerns, figure out what's concerning them, and try to either elicit help, either do a psych consult, get a social worker in there, maybe even elicit the charge nurse to try to help this person with whatever they're going through at that time. And this really will help with helping their whole well-being. And we talk about, we always stress teaching. So we really help patients make informed decisions about their care. We want to, like I said earlier, if a patient is alert and a patient is competent and they're receiving the information, they understand the information that you're giving them, they can regurgitate the information that you're giving them, and you can tell that they're knowledgeable about whatever you're telling them. And they say that they don't want to take their medicines. You can't make them take their medicine. If they want to decline certain procedures, or they want to refuse treatment, you cannot force them to do it. Even if the physician doesn't agree, even if we do not agree, we just can't make them do what we feel is best for them. So we just offer our support to the patient. And that's really what we can do. Now, if a person comes into the facility, they have a terminal illness, and they're like, I don't want chemo, I don't want radiation, then you support their wishes, and then you try to facilitate what they need. It's either getting a hospice. You can get them into hospice and help arrange that so they can have comfort care. And then lastly, we kind of say the same thing over again. We are a resource to the patient. If you find that a person is having financial difficulties with medicine, so they're about to be discharged, the provider says, oh, this is a medicine that we're going to put you on, and you know that it may not be covered by the patient's insurance, or they may call their pharmacy to see if the medicine is covered by the insurance, and it's not, then we have to advocate for our patients and either contact the provider to see if there's an alternative, because the patient is not going to be able to afford the medicine. And we tend, or if the provider says, no, this patient needs this, then it's trying to find the information of, just say, the pharmaceutical company who produces the medicine, to where we can say, is there any kind of drug savings plan, because this patient is unable to pay for their medicine that the provider feels that they need. Or we'll also elicit the social worker to help with that as well. So we do a lot of things. I don't know if y'all realize it. We talk about nurses, but we're everything. We are the PCTs, we're respiratory, we are phlebotomy. We do it all, and it all kind of stems on us. We coordinate that patient's care from the time that they're admitted to the time that they're discharged. And that patient is expecting us to more or less do our job. We are coordinating their care. And it can be hectic when you have, 4 or 5 patients, but we try to do our best to make our patients our priority. So when we move on, we're moving on to the protection of vulnerable populations. So a vulnerable population is a group of people who are at greater risk for disease, disability, or reduced lifespan because of a lack of resources or risk factors or a combination of both. So these individuals are socioeconomically disadvantaged. This could either be a low-income senior or an elderly person, a person greater than 60 years of age, who is suffering from the infirmities of aging. I mean, you have a person that's just getting, they're getting older, and every day that we live, we die. So as time, goes on, our age catches up with us. We're getting older, and we rely on family members to take care of us. And you'll see that a lot of elderly people do not complain. They don't complain of poor treatment at home because they don't have anywhere else to go. Another vulnerable population are younger people, children, or a person less than 18 years of age. They may or may not have a physical or mental health disability. However, they need an adult to help take care of them. They can't make decisions, or they may not be able, or they're not going to be able to make decisions for their own. So they are a vulnerable population. A dependent person, someone who's over 18, but who has a physical or mental limitation. And they're unable to protect their own rights. They're a vulnerable population. Individuals with a limited English proficiency, they're a vulnerable population. They may have difficulty understanding certain medical procedures, and that's why it's important for us to have medical interpreters so they'll be able to be well equipped with the information that we're trying to provide for them, so they'll be able to make good informed decisions concerning their care. Others would be incarcerated men or women, because if you think about it, a lot of people feel that those who are incarcerated, they deserve to be in jail, they did a horrible crime. But as we all know, there are people who are in jail that did not commit crimes. So they are a part of a vulnerable population. They can't speak up for and protect their rights. Persons who are substance abusers, they're a vulnerable population, because a lot of people feel that, oh, they did it to themselves. They don't deserve to have the same medical rights or rights as we have. But you have to understand that everyone has a story. And, I don't think anybody woke up one morning and said, I want to be a substance abuser. So when they come into our facilities, yes, we're going to see them. Yes, they're going to be individuals who are going to be more, they may request more pain medicine than others, but we have to understand that there is a story behind all of that, and we still have to provide them with adequate care and adequate pain management, because pain is subjective. So if they feel they say they're in pain and it's within the parameters, we provide them the care that they need. And then mental illness, that's a vulnerable population as well. We have individuals who may have schizophrenia or bipolar disorder, and if they are off of their medications, they are not going to be able to make informed decisions or be able to guide their care at the time. So we have to be an advocate for those individuals as well. Now, understand that as a healthcare worker, as a nurse, If we have reasonable cause to believe that a child, a dependent adult, an elderly person is a victim of abuse or neglect, we are mandated by law to make a report. Okay, and we're going to talk about that in a little while. So um, what you see on the screen, they have the Americans with Disabilities Act, and basically that's a civil rights law that ensures that people with disabilities have the same rights as everyone else. You know, it prohibits any kind of discrimination against an individual by providing federal protection to those with physical or mental health disabilities. So basically, that act helps improve the quality of life with someone with disabilities. The Patient Self-Determination Act, you may see this, you go to the hospital, they say, oh, sign this form right here about your healthcare rights. Now, no one really reads it because it's really small and it's kind of long, but basically, it's just saying that you have rights to your care. You can determine the care that you desire. It also goes on talking about advanced directives, which we're going to talk about in a little bit, about how you can determine what care you want to receive. Like we talked about, I don't want to be resuscitated. I don't want to have certain things done to me if I decline while I am in the hospital. So, but we'll talk about that in a minute. So with, now we're moving on to mandatory reporting laws. Okay, so federal and state laws require that individuals that work in healthcare environments, or, you know, nurses, you know, like us, that work in a healthcare facility. We work, if we work with the elderly, if we work with children, if we work with any of those individuals in that vulnerable population, we have a duty, like I said, to report any kind of neglect, abuse, or violence against them. We are listed as nurses, if not all, most of the mandatory reporting statutes. And these statutes include child abuse, neglect, medical neglect of children and the elderly, elder abuse in the community or in nursing homes, and even domestic violence. So as mandated reporters, we have certain conditions that we have to follow if we see violence, abuse, or neglect. And there are protections of us as well. You know, we don't want to just make a report just kind of just willy-nilly, for a lack of a better term. We don't want that. We want to be able to get the information that we need so we can make a good faith report, or have a good faith belief or reasonable suspicion that an injury or illnesses are a result of abuse or neglect. And if we do that, we're going to be immune to any civil, criminal, or professional licensure actions. So if we make a good faith report, if we ask the patient questions, document the findings that we have, and report the abuse, we are immune to any kind of civil or criminal actions. And when we make a good faith report, it has to be proven false by, you know, the family member or even the alleged victim. They have to prove that what we see and what we have documented is not what is actually occurring. And also, you know that when we do report, it is confidential. So the reporter's identity is not made public. You know, you may come into a situation where you have the data, you've assessed the patient, you've asked the questions, and you want to report this violence or neglect. And you have to. If you have enough data there, you need to let someone know. Your charge nurse, the house supervisor, because there are going to come times when they're going to say, well, what about nurse-patient confidentiality? Well, that doesn't fall under this. Another staff member or an administrator may not tell you to report your concerns, but if you're truly feeling that there is something going on, you need to report it. A family member may even plead with you, especially if they're the victim. They may say, please don't report this. But it's your duty to report, because if you don't report, you can face disciplinary action. They can take their license, they can take your license from you, and you can be criminally prosecuted. So, so it's very if you really feel that, you need to make sure that you let others know. If you work in a hospital, the hospital should have reporting forms, and they should have policy and procedures when these things occur. So as you can see, if you don't report, you'll be criminally prosecuted. But if you do report, and it's a good faith report, then you are immune to any kind of civil or criminal actions. So, okay, so I said all of that. So if you suspect abuse or neglect concerning one of your patients, what are you gonna do?
Report it. I have
report it. So before you report it, what are you gonna do?
Assess to make sure it's true. I have a question with that.
Yeah.
You mentioned that if you report something, it's, I guess, the patient's responsibility to prove their innocence. I'm just thinking about like law. You're innocent until proven guilty, but in this case, you're saying you're guilty until you prove your innocence. How does that work?
Well, I mean, if a patient, okay, so let's just say a kid comes in and they have a femur fracture. Okay. Now, a femur is a really difficult bone to break. So if the kid comes in and the parents said, well, they fell off their bike. Okay. Unless there's something else going on, some kind of medical condition that relates to the formation of the bone, it's hard to fall off a bike and break a femur. Now, if they were in a car accident, that's something different. So with that, you would assess the patient, you would talk to the patient, you would try to get a lot of information, because as you're assessing them, if you're suspecting abuse, they're going to have healed scars. They're going to have other healed things on them. If you've ever, you hear about children who are burned by cigarettes. Yes? All right. So, if you see a lot of healed circular marks that you can't say those were chicken pox, now the child comes in with a femur fracture, then you have a way of asking more questions. Yes, that's something that you will report. You will call child protection.
So is this partially instinct, partially, partially instinct and partially what is the word that I'm looking? Experience, like you've seen it before.
Well, you can say instinct because as you become nurses, you'll start to be able to kind of see where something is going. You know, you'll be able to see if a person is going to start declining before they may decline, or before, you know, uh, labs and stuff show. So I'm saying that to say in this, if you have a child who is always in the hospital for some accident, you know, I'm not saying this is the first time the child has ever been in the hospital and they don't have any identifying marks on them. They've never had anything wrong with them that you would initially think abuse. But if a child comes in and they have, you know, you're assessing them and you're like, well, oh, I see something here. What happened here? I see something here. What happened there? You know, and as you're gathering your data, you're seeing old scars, okay? Then you may look into the medical history and see that that child keeps coming into the hospital for various things. You know, then the child may tell you, well, this was what happened at home. So you put all of that together and you write your report. If you're not sure, you go to your charge nurse and say, this is what I've gathered. And this is what I believe that's going on. So if you know, as a new nurse, if you're kind of concerned about that, you elicit help, you get help with it, but you should report those things. It does not matter if there was 10 nurses before you that didn't do it. But if you're like, this just is not adding up, you know, I really need to protect this child, that is our duty to protect the child. Did that answer the question? I don't know.
I have a question.
Yes, it did.
Okay.
I have a question.
Oh, yeah, go ahead.
So you would report to Child Services for Children. Who do you report to for like adult abuse, like elderly or whatever? Do you
Adult protection.
Okay, so there is like an actual thing for that. Okay.
Yes.
Yep.
Yes.
I have a question too.
Yeah.
So let's say you suspect that there's a child that's being abused. How are you speaking to this child, trying to elicit this information? Is the parent right there with you? Like, I guess I don't understand just because they're a minor.
Right. Well, you know, there may be, if the child is hospitalized, unless the parent is there 24/7, they don't move to go to the restroom. I mean, you're going to have to find those windows where the parent may be away, and you're not, and it's more or less, you're asking questions because the child may not, you know, and also if you notice that every single time a child speaks, sometimes they don't speak, they just look at the parent for the parent to answer for them, or the parent is, you know, it's horrible for me to say things like that. It's not, I mean, it's just, but things that you'll notice if a parent is just overbearing, if the child can't speak without, just can't say, I want a glass of water, you know, and you'll kind of sense, well, what is going on? The parent won't let the child speak. The child won't even talk. Every time you ask the child a question, they look at the parent. You kind of gather things that kind of gives you clues. Is this something that we need to, and I'm not saying that you're going to do it on that shift, but I'm saying, are these things that I need to look at, put together, tell the next nurse and report, so we'll all be on the same page, excuse me, all on the same page when we gather our information and really make this good faith report. Because it's going to happen, especially if you work in pediatrics. Yeah.
If if we're to document, you know, something that the child said as far as it being abused, would that hold up in court? Would they be able to use those documents even though the parent wasn't there at the time that you asked them? Would that, you know, would even be able to be used in court?
It should be, but with that, we can always elicit, the hospital attorneys and things like that to guide us along. But I mean, now what'll happen is that what'll happen is if by the time, you try to go to court, the child may say, no, it didn't happen. Okay. So there are times where, you're still not going to, be criminally prosecuted because you made a good faith report based on it. But what'll happen is that that's kind of stays with the child. And so if something happens, and they'll just start building up evidence, because a lot of times there are parents out here that are not the greatest parents, but they still have their children. But as a nurse and as a nurse advocate, you want to make sure that you document the abuse. The parents may still keep their children. They may put them in foster care for a little while and then they get them back. But you've done your duty of recognizing it, because you definitely don't want to recognize that something's happening and then something happens to the child. And then, when they start interviewing and stuff and everybody says, well, the child did say that, but the parent said this, and then that really puts you in a really awkward position.
I have a question.
Yeah.
I know in like a clinical format, kids at like, I think starting at the age of 12 or 13 can go into a room without their parent. Does that translate over to like a hospital thing too, where you can like ask the parent to like leave the room while you talk to them?
Yes.
Okay.
Also, if y'all are like deciding to do home health, now we're talking about, in a hospital setting, but if y'all are doing home health or hospice or something, and you have a family member or a caregiver or something, if you hear them like threaten the patient or they threaten you, you just call 911. Don't wait to gather evidence or whatever. If you go in and you're asking the patient questions about their care and the family member comes in and they, threaten your life, you call 911. Because if they're threatening you, you can imagine what that patient that you're going in is being subjected to, because you're there just doing your job and making sure that you're caring for the patient and making sure that patient's being cared for. So, but you definitely, for that one, you call 911. If you ever threaten, you call 911. And if you're in the hospital and you're threatened, you call hospital security. But I don't know, did that answer your questions? Kind of? Yes, okay. Another question is, if a patient is diagnosed with tuberculosis, is that reportable? Is that reportable?
Yes.
Yes. Yes.
Yes, too.
Yes. Right, because that the person is they're a risk to the public because they have this serious infectious disease of the lungs. Okay. Well, I know y'all said some questions. Any other questions so far?
I have one more question about the abuse. I was just having a conversation with my mom when she was working at a nursing home, and she was saying that the nursing home got shut down because they caught the nurses on camera bathing the patients in bleach. Yeah, she was like bathing all the elderly people in bleach because of the odors from, the eliminator or whatever. But I'm asking that because what is it the same protocol to report an employee for abuse as it is like, if you thought it was a family member or something?
Well, if you're thinking that an employee, you would go to the, I guess, the charge nurse, whoever's in charge, and you can report the behavior. You can actually, and we'll talk about this in a second, you can actually question the employee. Like, I noticed that you're doing this, what are you doing? But if it's a true health, a health concern for the patients, you would go to management and see if they even know of this practice. They may not even be aware of the practice. And then hopefully at that point, they'll be able to shut it down. But if they don't, not shut down the facility, but stop that employee from doing those practices. But if you find that that doesn't happen, then you move up the ladder. I mean, and then you can report it, you can get the, elicit the help of an attorney, because if you really, if this is really wrong, you want to report that. You really do. And yeah, bathing them in bleach, that's horrible, but yeah. Any other questions? No? Okay. All right. Okay. So we're going to move on to ethics. All righty. So on the screen, you see that nurses have a duty to practice ethically and morally. So nursing ethics is it's a system of moral principles or standards governing our behaviors and relationships that's based on professional nursing beliefs and values. So if you have an ethical dilemma, who's writing on that? Is somebody writing on this? So if you have a ethical dilemma, if there's something that you have a concern about, you may need to discuss that with the ethics board. But understand that it's going to be hard to get into nursing if you have strong, not saying strong, we have to have ethic, we have ethics, but if I guess what I'm saying is that if you have difficulty taking care of certain people or doing things that are right, nursing is not for you. Our job is to do the best, like I said, we can to protect our patients and to be there for our patients. And so if you have certain beliefs that doesn't really go along with that, you're going to have a lot of issues when it comes to nursing and doing what is right. Okay, so our ethical principles, we have autonomy, beneficence, non-malfeasance, justice, and veracity. So we're going to go over each one of them. Autonomy. So autonomy is the right to self-determination. It's the patient's ability to make their own choices. They're not limited or imposed on by other people. They just have their right to determine their own care. And we as nurses, we need to honor this by respecting, like I keep saying, respecting the patient's decisions, even if those decisions conflict to what you believe in. You do what's in the best interest of the patient. So one of those things is informed consent, and there's a video on that y'all can look at. Informed consent, it's a process. We always go in and say, oh, the patient's going to sign their consent, but it's not really just the signing of the form. It's a process. The nurse is really, instrumental in a sense when it comes to an informed consent, because we have to make sure that the patient understands everything. That consent is written for. And then we have to make sure that the person who signs the consent is really the one that's supposed to be signing it. So if Mr. Jones is alert and awake, Mr. Jones needs to sign his consent. His wife can't sign his consent. If the surgeon has just come in the room, and patients are like this, and especially the older patients. I don't know, younger patients, it just depends. The physician will come in, the surgeon will come in, and they will shake their head the whole time while the surgeon is talking, like they understand what that surgeon is saying. And you've gone in and you've already assessed your patient. And with asking your questions, you determine that this patient is going to need more explanation. Or you may need to really use a lot of layman's terms and break it down for that patient. But when the surgeon comes in, they're just rambling on, and patients just sitting there just shaking their head like they understand. And then you ask the patient, so you're understanding what Dr. Smith is saying, and the patient looks at the doctor and they shake their head yes. And then the surgeon says, okay, sign here, and then they walk off. And then you're like, Mr. Jones, did you really understand what the surgeon was saying? And he says to you, well, not really, but he's the surgeon. And if he says this is, what I need, then I'm going to get it. And what you need to do is don't explain the procedure to him. You need to go and get that surgeon, call him up and say, I know you just up out of here, but Mr. Jones did not understand what procedure he's about to get done. You need to come back in and explain it again. Because if you try to go and explain the procedure and it contradicts what the surgeon says, or you leave something out, you are in big trouble. Okay? So don't do it, even though you may want to do it, but don't do that. All right? And in a consent, it's basically, the consent is allowing the patient to make a choice of that medical procedure, that they understand the risk and the benefits of the procedure, that they understand the risk and the benefits if they decide not to have the procedure. And that may include death. So they really need to understand that, so they can have the ability to make an informed decision. And if the person, like we talked about the vulnerable populations, if that person, and when I, limited English proficiency, but even with that, if they are, if they have, difficulty with their vision or their hearing, we need to make sure that we have either some kind of interpreter services, or they can write their questions so they can be answered if they're unable to speak at the time. And we have to make sure that we use layman's jargon, because like I said, a lot of our patients may only have a 4th or 5th grade education, or even if they've gone through 12 years of school, they may not understand all of the medical terms that they need to. Okay. Any questions with that? Okay.
Yep.
All right. So beneficence and non-malfeasance. So beneficence is the duty to do good. All right. Your actions should be to promote good for the patient. It's our obligation to do good. It's our duty to do good. Non-malfeasance requires that we do not cause harm. We prevent harm. We safeguard our patients. We remove our patients from harm. So we were talking about the nursing, like, you are and you're doing a home health visit, okay? I think I was talking about that when we were talking about if somebody threatens you. So you're going in and you're doing a home health visit, and you're seeing that the patient is wet, you're seeing that the patient has dried feces, they're dehydrated. It's your duty to make sure that if every time you're going in, the patient is in this condition. You know, you may go in and say, okay, well, the first time I'm here, okay, maybe something happened. But if you're constantly seeing this patient and they're constantly in urine, in feces, they're obviously unkept, they're obviously being undernourished. You know, we need to call adult protection. You know, we need to do this. We are preventing harm for our patient, and we need to safeguard our patient. So that is part of non-malfeasance. Or another thing would be, because these are kind of, you know, hard to put together. So another thing would be, all right, so we're going to do a central line dressing change. All right. And we don't really know what to do. So we go into the hospital's policy and procedure book, and we follow the guidelines of doing this central line dressing change. And that is also non-malfeasance because we have looked up the information so we do not cause harm to the patient by properly going through and performing the procedure based on the hospital's policy and procedure manual. Okay. Any questions with that? Okay. All right. So justice, you want to treat all our patients fairly. And this is seen a lot when we're talking about allocating resources. You know, how we were talking about, earlier we were saying that, you know, there may be something where, you know, we want to make sure that we treat all of our patients fairly. So regardless of their social or economic status. So justice comes into play kind of the same way. So let's just say, you know, with COVID going on, and they finally came up with, I guess, a COVID vaccine, and now they're running short. So an example of justice would be, you know, you're making sure that, you know, now that they're running short, that the COVID vaccines are allocated to those who are in greater need for it, instead of those who may not be in greater need, but, you know, their social economic status, you know, they believe that, oh, I should get this because, you know, I'm wealthy or something like that. You want to make sure that those vaccines are allocated to those who need them, and not just because, you know, they are wealthy. And so that's an example of justice. Veracity is really to tell the truth. Now, it's kind of challenging, and I think I talked about this a little bit when we were talking about a terminally ill patient. You know, if a patient has been terminally ill and they just, you know, maybe the provider has come in and they've told them their diagnosis, and just say that the family over the next day or so may have been talking to the patient, and now the patient is unsure of what they had just recently heard about their diagnosis, and they ask you, and it's really it's our duty to tell them the truth, even if the family members don't want to. Now, I know this is kind of hard, so if that does happen to you, even though it's in the chart, you know that the physician has told them about it, but they just need to know for sure again. And if you're uncomfortable with it, you can elicit the provider to come back in and tell the patient the truth about it if you're uncomfortable with it. But it is our duty to tell the truth. You know, if you're going in and just say, okay, let's just say that one of the pills that you're giving is a chemotherapy drug, and the family tells you, now don't tell them they're getting the chemotherapy drug. And then, but you're going in saying, you know, Mr. Jones, I'm giving you your medicine. Here's your lisinopril for your blood pressure. Here is, I don't know the name of the drug, but here is your such and such drug. You know, this is your chemotherapy drug. You're not supposed to, just because the family told you, don't tell them that that's a chemotherapy drug. You can't do that. You need to tell them the truth. If whatever you're giving them, you tell them what you're giving them. Okay. So you don't want to lie to your patients and you don't want to deceive them. Okay. So any questions so far? Okay. So we're going to take a 15-minute break and finish this up. So everybody comes back at 9:15.
I actually have a quick question. So, in a circumstance, as far as giving out a diagnosis, we don't initially give out a diagnosis if the patient doesn't know. That would be the doctor.
Right, right.
Okay.
But if like I said, if the provider or the surgeon has gone in, it's been documented that they've gone in and explained to the patient, and you know, strange things happen. You know, the family member may tell the patient, "You didn't really hear that. That's not what they really said." You know, if it's been documented that and you know that the surgeon went in or the doctor went in and told them that this was it, you can, if they say, well, did the doctor really tell me that that's what I had? And you would say, well, yes, based on the record and what the physician said that he had told you, yes, that's what you have. Now, if the family members say, don't tell them, if you're uncomfortable with that, you can call the provider and have them come back in and say, can you go back into 305? Because, and just kind of reiterate what you said, because there's some confusion between the patient and the family.
Okay. But if they're trying to ask us for results for a test and the doctor hasn't spoken to them yet,
oh, yeah,
we just inform them that your doctor's going to come in and speak with you about all your results.
Right.
Okay.
Yeah.
Just wanting to clarify. Thank you.
You're welcome.
Come on, you coming? Come on.
Mom, your sound's on, Mom.
Lower your voice.
You finished with this?
Stop.
I can't remember how to mute everything.
Leave it right there. I'll use it.
That's Ashley. I don't know how to mute her. God, I don't know how to mute her.
Hey, Papa. You know where the German chocolate is? Why now?
It's in the bouquet. It's in the container.
Move.
Blue container.
Move.
Look, hey, Mom.
Okay.
German chocolate. What?
Oh.
I think that tastes good.
Your phone is
What
on.
is that? Is that? What is that?
German chocolate.
Hey, Ashley, you're not on mute.
Okay, well, right now I'm
And
fixing a German chocolate.
Y'all, I
brownie
can't
snack.
figure out how to put her on
Snack.
mute either. I'm.
No, dessert muffin.
I can mute my audio. Why can't I mute? Where's her? Where is she? Ashley.
I'm gonna talk to your cousin.
Ashley. Where is Ashley?
Twinkle, little feet.
Miss Harris. Miss Harris. Hey, this is Ashley Gerald. Where you needed me?
No, we can hear you. I was trying to
I
figure out how to. Yeah, I found. I'm gonna start. I'm gonna mute you when I hear you. So I'm gonna mute you.
apologize.
That's all right. All right. We will start the second half. There we go. Okay. Oops. Let's see. All right. Okay. Y'all can hear me, right? Hold on. Yeah, okay, good. All right. So before we kind of get into ethical dilemmas, I'm just going to kind of go over some ethical issues that we as nurses encounter. When we sometimes we are unsure what moral principle, I guess, we can apply when we just start off as nurses, because we're really not sure of what we're supposed to be doing. You know, you may experience some moral uncertainty, you may have some moral conflicts when y'all start. You may have some, you know, moral distress that you may experience, especially, you know, if you know the right thing to do. But just say the hospital that you're working at has these limitations or these constraints that, you know, kind of keep you from doing what's right. So I guess it's kind of like, you know, you'll have a patient, because what y'all will find out that hospitals have formularies. And, you know, on the formulary, they have a certain group of drugs, and they try to keep those drugs as cheap as possible. So, you know, because it's a business about money. Everything is, you know, revolves around money. So, but a patient may need a drug that can really be beneficial to their betterment, but because it's not on the hospital's formulary, the patient can't receive it. And that may cause some moral distress for you. You know that it's out there, you know that it's beneficial, but the hospital doesn't want to pay for it. And, you know, and that could adversely affect, you know, the patient's outcome. So that, you know, you may experience some moral distress because of that. You may even experience moral outrage, and that would be like you're witnessing an immoral act by another, but you feel powerless to stop it. So like the young lady was talking about, the, you know, the healthcare workers bathing the patients in bleach. You know, you're like, this is definitely not right, you know, but you know, certain individuals who may have known that this was going on, and it could be because of management, or, you know, they just felt that they were powerless to stop it. So, you know, that would be kind of an example of moral outrage. Another example, you know, when we talk about ethical issues that we encounter, is abortion. So it's illegal, but what if the mother will die if the baby is born? So that could be an ethical issue that you may encounter. Let's talk about impaired nurses. And it may happen. Hopefully it does not happen in your career. It's happened in mine. You know, you may have, you know, we as nurses are obligated to protect our patients. And if we notice that our coworker is impaired, you know, we know that you know, we have a good hunch that they're taking a substance, you know, while at work, we have to report it because it's our duty to protect the patients. If you know that our coworker is using a substance that can alter their ability to react fast or to think quick, that can be detrimental to the patient or the patients that they're taking care of. So we have to report it. We have to tell our charge nurse. We have to tell our supervisor. Yes, you know, you feel kind of bad because you're, you know, I'm telling on my friend, because it may be a friend, but you have to tell the supervisor and you have to follow any state regulations. So if that means that, you know, the charge nurse finds out and then, you know, they do a random drug screen, the person is positive, or, you know, you find out, you know, because we've had nurses in the bathroom overdose with needles in their arm. We've had, you know, we found out that nurses were shooting up between their toes. I mean, it happens. So if we find that these things are occurring, we have to tell our supervisor and we have to follow up with any kind of state board regulations, because their actions could really cause serious harm to patients. And we have to be an advocate for our patients, but for all patients. Another ethical issue that we may encounter is even organ allocation. You know, how do you feel if a wealthy person, because we know there are several billionaires, you know, they just keep getting an organ? You know, they're not trying, because it's hard to get an organ. You can, if you do something small wrong, they may put you at the bottom of the organ recipient list. But you have a wealthy person and they just keep partying and doing whatever they want to do, and they just continue to keep getting organs. You know, how do you feel about that? You know, and that is an ethical issue that, you know, you may encounter. So those are some things to think about. Now, ethical dilemmas. We'll move on to ethical dilemmas, you know, situation that involves actual or potential harm to someone or thing. And under ethical dilemmas, you know, we have, under ethical dilemmas, wait, hold on. There you go. Under ethical dilemmas, we talked about abortion, talked about you may have to deal with, you know, individuals who are, you know, HIV positive. I mean, that's just, you know, what we do. If you have an issue with that, you're gonna have to really figure out, you know, why you're in nursing, because like we said before, regardless of a person's medical condition, social, economic status, we are there to advocate, take care of our patients, and promote their physical health and well-being. When we talk about some end-of-life situations, that's where, and we're going to talk about advanced directives and assisted suicide. You know, these are other things that we will definitely come into contact with during our nursing career. So, okay, so in advanced directives, this is what it includes. It's a directive to the physician and the family or surrogate. This is the most common. So it allows the patient to decide if they want to end treatment or withdraw treatment. And this is called a living will. A medical power of attorney, this is where the patient designates another person to make their decisions for them. You have an out of hospital do not resuscitate order. So this is the person, like, they're on hospice and they refused any life sustaining procedures. You know, they don't want to go to the ER. Just let me sit here and let me die. Okay. And some people have, you know, a lot of, you know, the community doesn't like, well, they're opening up to it more, but hospice early on, people really couldn't, they didn't, it was difficult for them to understand, you know, but a person has a right to say, I don't want anything. I just let me, just give me some comfort and let me stay home and let me go. A declaration of mental health treatment. I've never actually seen one. I mean, it's, you probably will see one if you work in a behavioral health unit, an inpatient behavioral health unit. But what this is that the patient can determine their mental health treatment when they're competent. So when the person is alert and competent, they can make decisions about their mental health treatment. So if that person is unable to make decisions, and either a court or two physicians has to determine if the patient is incapacitated and unable to make decisions based, you know, for their medical treatment, they will institute this declaration. Now, this declaration can say, you know, if I'm unable to make medical decisions about my mental health treatment, I'm saying through this directive that I don't want electroconvulsive therapy. I don't want ECT therapy. I don't want any psychoactive drugs. I don't want short-term admission. So that would be like your PEC where you're there for 72 hours. And I don't want, you know, to be in a hospital for 15 days. But that would be their CEC. And this is in Louisiana. I don't really hear of it, you know, at all, really. But, you know, this is a directive that they do have in Louisiana. And that's just to give you some information on that. We talked about, well, the living will, and an advanced directive is not the same as a DNR, which is do not resuscitate. So advanced directives are written in the hospital after the doctor and patient or patient's surrogate or caregiver decides to withdraw life-sustaining treatments. So the advanced directive allows the patient to decide to withdraw treatment, but a DNR is, I don't want to be intubated. I don't want chest compressions. I don't want CPR. If something happens to me that requires those interventions. Advanced directives, you know, lastly, are documents that state in writing the patient's, and like we said before, their healthcare wishes, and, you know, removing interventions if they ever become incapacitated. So that's what that is. When we talk about the right to die, you know, euthanasia, as it says, is the intentional termination of life. The patient requests to die. They, you know, they wish to die. So, you know, this is, of course, an ethical dilemma. There is active and passive euthanasia. It's generally illegal, but may be legal under certain circumstances. So active euthanasia is like we hear about Dr. Kevorkian. You know, they are involved in causing the person's death. Okay. Passive euthanasia is the hastening of death by altering some form of life support. So, you know, we take the patient off the vent, we withhold food, we don't put the peg tube in to give them tube feedings, we don't give them fluids, we don't give them oxygen. And passive euthanasia is more accepted by the medical community, especially at that end of life. Sometimes patients, you know, who have who are mentally or I'm trying to say who are neurologically gone. You know, they have that flat EEG, so there's no brain activity, but you know, they may still have oxygen, and just withdrawing the oxygen will allow them to go peacefully. So that would be kind of a passive form of euthanasia. When it comes to assisted suicide, the patient actively seeks a nurse or physician to help them commit suicide. It's a criminal offense in all states other than, and I may be missing one, but Oregon, Washington, Montana, Vermont, and California. Usually with assisted suicide, you know, the patient is given prescriptions that are in legal doses, but the patient decides if they want to use them and take them all at once to assist in their death. There is a uniform determination of death act. You know, a patient is dead if they do not have, you know, they have cardiopulmonary death. You know, so the heart stops and it stops pumping the blood through the pulmonary system. And then there's neurological death where the brain is dead, the EEG is flat, and there's no electronic pulses at all. So those are two, you know, two conditions of determining death. Okay. Okay, so our rights in ethical situations. You know, nurses, we have, oh, before I go on, does anybody have any questions about that, the assisted suicide and all that kind of stuff? No?
What were the two determining? You said pulmonary, was it neurological or cardiovascular?
It's cardiovascular, cardiopulmonary death, and then it's neurological death. So, you know, we as nurses, we have rights. You know, we have the right to refuse to participate in giving care to a client if we do not agree. This is held up by the American Nurses Association. You know, we need to make sure that we're not abandoning the care. So if we're in the hospital and you're just like, I can't do this, you know, you need to make sure that another nurse can take over that patient's care. You can't just abandon them because you don't want to be, you know, a part of a certain procedure that's being done that you feel that is, you know, you're having an ethical dilemma with. You have to make sure that somebody else takes over that care, but you can refuse to take care of patients. And it says the Joint Commission requires employers to establish policies to address the staff requests if they feel that it conflicts with their cultural values or their religious beliefs. So I have a little video in there that just kind of, gives a little information on our rights as nurses during ethical situations. The ANA, so the ANA has a code of ethics, and I have, if y'all at y'all leisure, y'all can look through all of them. But basically, it applies to all nurses in all healthcare settings. They have determined ethical principles that are agreed upon by the nursing profession. There are a set of standards of conduct and behaviors that nurses are supposed to exhibit. And, it basically kind of talks about where we've said it before, our primary commitment is to the patient. We have to make sure that, we just demonstrate compassion and respect for our patients, regardless of their status. We make sure that we promote their health and welfare. It also talks about us being accountable of our nursing practice. It talks about, having to where we need to maintain and continually educate ourselves. So once y'all get out of school, you're going to have to go and get continuing education, credit hours, and that just kind of continues your growth as a nurse. And then, the code of ethics also deals with improving the healthcare environment for providers and their patients. And I don't know if y'all heard about it, but I can't remember what hospital, but we know that because of COVID, a lot of nurses have been picketing and stuff because, they feel that hospital should improve healthcare environment. So they're allowed to do those kind of things because of organizations and like the American Nurses Association and stuff, and having them speak for us. There's also an International Council of Nurses. They also have a code of ethics. I put the link there, and that just basically talks about they say that there is 4 fundamental responsibility of nurses, and that is to promote health, to prevent illness, to restore health, and to alleviate suffering. And that is what we do. Moving on to restraints. Restraints, if y'all haven't seen any, y'all will see them in your nursing practice. You may even apply some at one point in time. But restraints are any manual, physical, or mechanical device or equipment that's wrapped, buckled, tied to patients' arms, their legs, the trunk of the body to restrict movement. Now understand, there are, restraint vests, but a person can die from a vest. You have the person strapped in the vest, and just say you raise the head of the bed, just say they're eating, and you leave them up, and just say it's an older person, they fall asleep and they start to slide down and they choke themselves on the vest. So, that's why it's important for us to always go in and check our patients, reassess our patients, and we'll talk about that in a second. Restraints can be, like I was saying, to the wrist, they could be to the ankles, they can be mittens, vests. A restraint can even be you tucking in the sheets real tight. It could be all of the 4 side rails up on a bed. Just anything to try to prevent that patient from getting out of bed. Now, you'll notice that a lot of facilities, they'll say side rails up ×3, because if you put all 4 up, that can be viewed as entrapment, and a patient can get entangled in it, trying to climb over it, And so now they're falling from the height of the side rail instead of, I guess, the low position of the bed, and they can injure themselves. And then you can, get in trouble. We can't use restraints as a form of punishment. We can't use them as a convenience. We can use them to prevent the patient to leave. But, understand, we don't really abuse using restraints. But, if we have a tendency of, you can overuse them and some things can happen, even though the intention wasn't to punish the patient or it wasn't a convenience, but, your goal is to really try not to use restraints. Now, we know you're working in the ICU, in the hospital, the person comes in, they may not be fully lucid, they put an NG tube in, they may have a central line in, they have a catheter in, and they're disoriented, so they're just trying to pull out everything. Yes, we know that restraints are going to be used. But the goal is to use the least restrictive measure. Okay, so let's just say the patient came in and you want to try all of the least restrictive measures first, and then you did all of that, and then you put on the wrist restraints. You can do that, but as soon as you put on those wrist restraints, you better call the provider to get an order. Because if you don't, and just say you get busy and something happens and those wrist restraints stayed on and you don't have an order on the chart, you're going to be in trouble. So you want to make sure that you try to use all the least restrictive methods first, but of course we don't want them pulling out IV lines and NG tubes. But after you've tried all of those least restrictives and you put on them wrist restraints, you better call that provider, because you need an order. So with a competent patient, I know y'all already know this, if they don't want to comply to their care, can you restrain them? No. You try to restrain somebody who is competent and alert, you're gonna be charged with assault, battery, and false imprisonment. If they don't want to comply to their care and they're competent, you let them sign paperwork so they can leave against medical advice. Even though you may say, well, if you get on the road and you try to go somewhere else, something may happen to you. If they want to go, you let them go. But that's the competent person. That's the person that's alert. When we talk about least restrictive, they can be chemical or physical restraints. We talked about, and chemical could be something as like Ativan. And the physical is like we talked about, the mittens, the belts, the vests, but restraints should really be used as a last resort. And you have to document the least restrictive first. You have to document that you tried it and it was unsuccessful. And all you had left was to actually put the restraints on them. So some examples of restraint alternatives can be a bed alarm, a chair alarm. It could be, so if they try to get out of bed, so just say you put the 3 side rails up and they try to get out of bed, the bed alarm will go off to let you know, hey, the person's trying to get out of bed. You can have a family member, as some of you have seen already. They may have a sitter in the room with the patient. You may try to distract them. They put on the television. They may try to do some diversional activities. Every time you go into a room with a confused patient, you want to reorient them. You're at the hospital. it's, you know, you tell them the date and the time just to try to reorient them, because they could be confused. You always want to make sure you talk to them in, you know, a calm voice, a soothing tone. You may try something where you limit the amount of people that go in the room so they don't get, you know, they may, with them being confused and they see all of these different people, it, you know, it may cause them to, you know, be scared and want to leave the facility. And so you want to, you know, but they're not with it, but they're fearful because they see all of these people. So, you know, these are just kind of ways to keep them calm so they can stay in the bed. So you're just trying to prevent them from becoming agitated to where you may have to use restraints. Another thing could be sometimes an elderly person just trying to get up to go to the bathroom, you know, wanting something to drink can be misconstrued as, you know, oh, they're trying to get up, they're trying to get up. But if you go in and you do, you know, your, you know, I don't know, the 5 Ps and stuff, you know, that could probably prevent a lot of these things. And that action that the patient is doing and being misconstrued as them trying to get out of the bed and hurt themselves. Even something as simple as eyeglasses. You know, the person tried to get out of the bed and they fell. So you're like, oh, good, you know, we need to, you know, put restraints on them because they're trying to get up and they're going to hurt themselves. But it could have been something as simple as the patient needed his glasses. He just couldn't see. You know, he just didn't see that wire on the ground that he tripped over. You know, and sometimes, you know, we as nurses, and we'll see it, we may be overwhelmed, we may be flustered. And when things like this happen, you're saying, well, I'm just going to have to restrain him. And it could be something very simple as the man fell down because he couldn't see because he didn't have his eyeglasses. Okay. So okay. So also something that you need to do, you know, we're reorienting a confused patient, but what other things can cause a person to be confused? And if they're corrected, the person's fine.
Blood sugar. Blood
sugar, yes. They can have a low blood sugar that can cause a mental status change. Anything else?
UTI.
Sodium.
UTI, yes. If you work in the ER. I'm sorry, what you say?
Sodium.
Sodium, yes. What else somebody said?
Fluid and electrolyte imbalances.
Okay, yes. That went along with the sodium and even an ammonia level. You know, those things can alter mental status. So but we should be looking at labs every day. But, you know, if somebody comes in, just say you're working in the ER and they come in, you know, just having an idea of what their blood work is and saying, you know, this is an older person, maybe it's a UTI, can make it be more where they're not combative, they're just confused and it's not them, it's something that's going on with them. Okay, that's good. So with restraints, you need an order, a verbal order every 24 hours. If one isn't written by the MD, we have to go in and assess that patient every 2 hours. We have to assess their skin, we have to assess their circulation, we have to assess their response to the restraints. You know, are the restraints making them more agitated? You know, you just have to kind of assess them constantly and document. It's all about documenting. And we have to take off the restraints. We have to make sure that they can move their body, do some passive or active range of motion. We want to offer them chances to go to the restroom, offer them food and drinks, and, you know, and then really reassess them. Is the patient getting better? Can we hold off on putting the restraints on them? And you document that because, okay, you put them in the restraints, you know, they were in the restraints, you've done certain interventions, we're taking them off. you may have to put them back on, but you can show in your documentation that you still was trying to do other things, because you really do not want to get yourself in any kind of legal issues because of the inappropriate use of restraints. Because if so, it can cause a lot of issues. You can be prosecuted. You know, we talked about that assault and battery, negligence, the wrongful death. You know, you put that vest on them and they just slid down in the bed, and then, you know, they choked, you know, and that if it's an institution, they can lose their ability to receive Medicare and Medicaid funding. And for us, we can have criminal prosecution, and we definitely don't want that. So it's all about documenting. And we talked about this toileting. Okay, all right. It was a little behind. All right, so this is just on there. I'm gonna just tell you, I'm not gonna test y'all on the Louisiana State Board of Nursing and this council, but when y'all graduate, it is good to go in and look at what RNs can and cannot do, because that's where we tend to mess ourselves up. We tend to do things that we are not supposed to. So it would be good. And if someone or an organization is asking you to do something, you're like, this is not part of my scope of practice, please just don't do it because the institution is telling you to do it. Go to the Louisiana State Board of Nursing, look it up. If you need clarification, there are individuals there. You send them a little email and they will respond back to you, and they will tell you if, you know, you don't even have to disclose the hospital or anything, but you can tell them the situation, and they'll tell you if it's within your scope of practice or not. Because this happens to a lot of people. And I'll give a quick example. You have a nurse, she's working in the ER, and he's working in the ER. They're really, it's night shift, and they're really close with the providers that they work at night. And the provider's going in and doing an IND, an incision and drainage of an abscess, and the nurse goes in and they allow the nurse to make the incision. And another nurse sees it, and they call state board on you because that is the outside of your scope of practice. It could be something as simple as that. Somebody's watching you and you don't even know they're watching you, and they call the state board on you. So make sure that you know what's in your scope of practice. It will happen. So that's just some information on that. And that the National Council, they kind of do the same thing. They, you know, make regulations for nurses, but they're big on creating the licensure exam. So I just wanted to put, those are two references when you get out of nursing school that you may have to reference or kind of browse through and see what regulations we have, especially the Louisiana State Board of Nursing. All right, so moving on, I think professional boundaries is our last thing. Okay, so with professional boundaries, I did put a little video on there for y'all to kind of watch, but you know, boundaries is that space between the nurse's power and the client's vulnerability. And there are times when these boundaries are crossed. It may not be on purpose, you know, it may be done to fulfill a therapeutic need, but we have to be very careful of crossing these boundaries. Because if there's too much of this crossing of these boundaries, you can get in trouble. And we'll talk about a little bit of that. And then also sexual misconduct. You know, We've heard some things on the news about, you know, people doing sexual things on incapacitated people. You know, it may, you know, you may find someone that actually does this in their professional, in your professional practice. You may hear of this, you know, and that's of course definitely, you know, a boundary that was definitely crossed. But okay, so some boundaries that y'all may run across. Excessive disclosure. So you'll have a nurse, and sometimes this happens in home health, where you'll have a nurse where she's just saying, I can't pay my car note, I can't pay my light bill, I can't, you know, they're just giving all of this information in front of the patient. That is none of the patient's concern. That's a boundary. They're crossing that. You may have a nurse that always is in the patient's room, and you know, they're over in the patient's room. They have these little secrets between the two of them. The nurse is very guarded about the relationship if somebody questions them. Another boundary would be that super nurse. Oh, only he can take care of this patient. Hey, nobody else can take care of this patient like I can take care of the patient. The patient, you may have had the patient on Tuesday on the West Wing. Wednesday, you're on the South Wing. But you still on the, what did I say, the West Wing, still at the patient's bedside. That's not even your patient. Why are you even in the room? You know, the patient belongs to a whole nother nurse. So when we see behaviors like this, it could be done and the nurse may not even realize that they're doing it, you know, but you need to pull that nurse over to the side and you need to discuss this with them. Are you aware that you are always in 3345's room? You know, because you have your own set of patients down here. This is concerning. And, you know, because if you don't intervene and kind of pull them over to the side and talk to them, this could cause harm to the patient. And you really need to notify the supervisor, because trust me, those who do, you know, certain sexual misconducts with the patient, it just didn't happen. They went in and they were doing different things and it kind of built up. And then they felt that, I guess, nobody paid attention to what they were doing anyway. And that gave them the opportunity. So when you see that professional boundary being crossed, you need to pull that person over, you know, to the side and say, hey, your actions that you're doing does not make any sense. And if, you know, and this could cause harm to the patient. I've had nurses who was always in the patient's room. Next thing you know, the patient and the nurses get married. You know, that's just not what's supposed to happen. That is definitely crossing professional boundaries. Another things that you may see, and I think I talked about this, the nurse singles out the patient's the patient's treatment. They're always in the patient's room. You find out that the nurse is getting money and gifts from the patient. Flirting with the patient is never, ever okay. It's not appropriate. I don't care if it's Brad Pitt. You just don't flirt with Brad Pitt while he's in the hospital. If you find that the nurse is very, very protective of the patient, you know, you have to question that. And then if you notice that the nurse is failing to protect the patient, that's still an issue. So that's something that we need to address. Because going back to the other, you know, they're always in the room. A nurse may not even realize that they have feelings for the patient, I guess. You know, so you really want to say, you know, do you have some kind of feelings for this person? Because the charge nurse needs to make sure that you never take care of this patient while they're in the hospital with you. And last thing, y'all, please do not post anything on social media about any of your patients. They have had instances where student nurses, and even nurses, but just say student nurses have gone in and have taken pictures of the patient and posted that on social media. You will get kicked out of school. So please don't do it. Even like I said, even if it's Brad Pitt and you wait till he is discharged, run down the hall, or wait till he gets outside and then take your picture and go back inside. But don't do it while you're actually working, on the unit with the patient as he has the NG tube down his nose or something. Please don't do that. I just have to say that because people are doing it for some reason and they think it's okay. And I have a video on boundaries, another video on boundaries. And so basically what this picture just kind of shows is that, when we have to have a balance. We don't want to give too little attention to the patient because that's going to be seen as neglect. That's going to be seen that you don't want to be bothered with the patient, or you're just not interested in the patient, or you don't really care about their betterment. But then you don't want to give too much attention because now you have, you're going to be concerned about crossing those boundaries. So it's just kind of maintaining a balance when it comes to patient-centered care. So just kind of ending up, you want to, when it comes to nursing and nursing advocacy, you want to be aware of your beliefs, your cultural beliefs. You want to be cognizant of those feelings. You want to make sure that you're observant of the behaviors of other professionals. Like we talked about the impaired nurse. It's most likely going to happen. So you really have to make sure that you watch the behavior of others because, like I said, you really need to make sure that you're protecting, and it's your duty to protect the patient. Always act in the best interest of the patient, because this relationship that you have, this nurse-patient relationship that we have, is built on trust. It's helping give the patient hope that they're going to get better. You have to be sensitive to your patients. Sometimes it's hard, but we have to be sensitive to the patient's needs and even our own needs. Because our job, like I've said before, is fulfilling our patients' physical, emotional, even spiritual needs, through our knowledge and, and our skill. So, and you may even have to stand up for your patients' rights. You may have to defend them. But you really gonna have to learn to put your personal feelings aside and your perceptions aside, because it's all about the needs of the patient, not even their caregivers. If the patient, like I said, is competent and they're able to make their own decisions, it doesn't really matter what the caregivers say. Any questions?
Hey, Ms. Harris, one quick question. Is it within the nurse's scope to remove restraints, or do we need
oh no, you don't need an order for that. Because as we're going in and as we're assessing the patient, we can remove the restraints. Okay, so the restraint order lasts for 24 hours. So we can put them on and take them off as many times as we want within that 24 hours. After that 24 hours, so usually you'll find where if over that course of 24 hours, there's still a need for the order, they'll start trying to get in touch with the provider maybe 2 or 3 hours before that order has run out to make sure that there isn't any gaps in time. Because once that order is done, you got to take them off regardless of what's going on. So that we try to, you're going to try to make sure you stay ahead, and make sure. So like if you see them rounding, or when you're giving report in the morning, you say, hey, I didn't call them last night. These restraints are going to be up at 11 o'clock. when they round in the morning, or if I see them, I'll try to get the order renewed or get a verbal order from them and write it down. And what happens is that they'll go in and co-sign it later.
Okay, thank you.
Yeah, you're welcome. I know I ran over time, y'all, sorry. Any other questions? No? Nothing? And I am recording this lecture. I mean, I don't know. It's a lot of this, I think y'all already kind of know. I know that y'all had some advocacy in level 1, so it's probably, you know, kind of overlapping, but I'll figure out how to post this, and I'll post this today.
Thank you.
All right, anything else? No, and y'all signed in, right?
Yes, ma'am, thank you.
All righty, y'all be safe.
Thank you. You too.
You too.
All right.